I just wanted to share with colleagues the flu vaccination. I found this particular poster from Public Health England very, very helpful, and perhaps maybe all community pharmacists and other pharmacists giving vaccinations this year may just want to have this on the desktop as an aid memoir when giving out flu vaccinations this year. Okay, so without further ado, I think we'll move on to the next item, which is how we're going to sort of be using remote consultations. And Darush, probably I've been working with him for many, many years, starting with the Stop Smoking and Smoking Cessation Services in Southeast London. But I think Darush has moved on to that to become a consultant in inhaler techniques, etc. So Darush, what are the challenges facing you in your GP practice, having to advise asthmatics without actually being able to have face-to-face contact? And perhaps first of all, you want to give a slight praise to your background, and then we can kick into your presentation.
Thanks, Raj. Sorry, Bipin, for those technical bits there on your presentation. So my name is Darush, and I'm basically a community pharmacist for my background, 20 odd years. I then started in 2014 working with Barnet CCG, which is now North Central London CCG, Barnet Borough, and I'm a respiratory lead pharmacist there. I'm also doing quite a lot of work with the Primary Care Respiratory Society, part of their executive committee, and learning a lot from our GP colleagues, nurse colleagues, pharmacy colleagues, of course, and various other colleagues and patients, of course. So over the years, I think with the Barnet project, the first thing I really wanted to focus on there was optimizing inhaler technique, because one of the things is if we can't get the medication to the site of action, then there's no point in having that inhaler. And as medicines management pharmacists, we're looking to optimize those treatments and reduce waste as much as possible. But most importantly, we're there to reduce harm to patients as much as possible. So what I'll do is I'll just start off with a little bit around what went on in when COVID was announced. We had obviously a real issue with stock, especially with inhalers. We had a 400% increase in demand on inhalers, and it was so important that the medicines management teams and the GP practices. I do some work in some of the GP practices and as an independent prescriber as well, and we were finding that we were prescribing by brand inhalers, and it was great, but it was no good when the stuff was out of stock. So it was really important that we communicated with the local pharmaceutical committee. So the Middlesex group were fantastic with alerting us of stock issues and the community pharmacies. And what was important was that when there were shortages of stock, especially for medicines for adults and children, we're finding there was an issue with Clenil, for example. We needed to make sure that we could offer a safe alternative. So what this article was looking at was how in the future, if there are issues again with shortages, how it's important that we have alternative treatments on formularies that are the equivalent. So it makes it seamless. But obviously, if we're changing patients' medication to something that's therapeutically equivalent and in the same device, we need to make sure that's communicated really well. And we're using things like WhatsApp messaging and news bulletins, and the LPC were communicating through. We also connected with the Royal Pharmaceutical Society London Northwest group, and we got the message out even nationally as well. But while we were communicating that with patients, there was an upsurge in, for example, inhaled corticosteroid prescriptions. That was great news, because I think patients were concerned about their lung conditions, and they obviously wanted to become hopefully more adherent to treatment. But while we were at it, we needed to make sure those high value interventions were there, and it was all done part of a shared decision making process. And I think now advice to all of you really is if patients have been stockpiling of medicines, it's really important now we ask patients to use up what they've got now and make sure we have enough stocks for everybody if stock issues were to arise again. But as I said earlier, optimizing inhaler technique, it's been hard for me to go and see patients face to face, but GP practices have had, we've been fortunate that we've been able to use free software like AcuRx, for example, where we can text message patients, we can you do video consultations with patients, and we can do telephone consultations. But for something like inhaler technique, it's you can't really do a telephone consultation for inhaler technique because 9 out of 10 of us healthcare professionals, for example, are not able to use a metered dose inhaler technique, for example. So it's important that we keep up to date and competent to do it ourselves, and we can follow the 7 steps to good inhaler technique set by the UK Inhaler Group standards. So what I've been sharing with my colleagues in primary care and in community pharmacy is this medicines management safety pyramid. We still need to make sure that patients are diagnosed. Look at the history. Have they been diagnosed correctly? Check for. There's a big push around, obviously, low carbon type inhalers, but we need to do this the right way. We don't switch people to lower carbon alternatives. We need to make sure we find the right device that fits the right patient, and so what we've been trying to do is if we can optimize treatment with good technique, and I've been sharing videos like this, for example, spacer videos, for example, with colleagues, which I'll just show you a clip of this, just so you get an idea of what we've been sharing in training. And hold technique, and there's also tidal breathing technique, with mask or without mask. So it's important that you find the right spacer device for the right patient. So let's do a demonstration of single breath technique. I'll do that first of all with a large volumatic spacer. Thing to be aware of is the compatibility of a metered dose inhaler with the spacer. So this one fits snugly, but it doesn't fit every device. Let's assume we prepared and loaded the metered dose inhaler. This is a single breath and hold technique. So I think you get the idea, and there's a multi-breath technique there, which I did with the aero chamber device. But really, I think with the technology we've got, and if people can get access to that within the practices, within the pharmacies, we can actually utilize the camera close up like that. And of course, we can share other videos from Asthma UK and also Right Breathe as well. So there's lots of good resource out there, and we can share links to patients for the patient-facing videos, and then we can share links like this for when we're doing training about the 7 steps. As you can see with medicines optimization, it's far more than inhaler technique alone. So we need to be aware of identifying high-risk patients. So this is where searches on our systems, for example, patients over-reliant on their blue inhaler, underusing their ICS, and also making sure that we prescribe by brand is some of the things that we mention here. And of course, if we don't optimize the inhaler technique, then that will maybe result in more side effects for the patient and escalation of treatment, and it can result in hospitalization and attacks, of course, to the patient. Patients should be, as Bipin and Raj have highlighted, living well with asthma, and they can live well with asthma. And I think the key ingredient of inhaler technique is key, and we can't forget that during this time where it's hard to see patients face to face. I know community pharmacies are doing that, and I think if they can do that safely, then it's important that we do that. Just to be aware as well, ongoing training and keeping up to speed. There's been so many updates, and the place I would go to is, which is primary care related, is the PCRS, because they'll give interpretations of and summaries of, for example, rapid guidance from NICE, anything COVID related. There's also a conference coming up very soon, and these are just a snapshot of some of the learnings we can get from our nurse colleagues, respiratory consultants there, and researchers. Some excellent sessions. And if you wanted to get to see more on inhaler technique devices, I'm using something called Loom technology there. You can also see that at the conference this year. So staying up to speed, keeping fit to care is something, again, PCRS have highlighted. I always get colleagues in GP practices saying, you know, I've been asked to do these reviews, but I'm not, where do I go? What do I need to learn? And this is, again, the place I would go and suggest that people do. We say no delegation without education. Really important we have the skill sets to do things. In this time of where people can access technology, and by the way, a lot of people still can't, and we've got to think of our lower socioeconomic groups who, for example, won't have good access to internet and maybe digital phones. It's important that we don't just rely on this. So I know Martha's going to talk about this a little bit later on. So just bearing in mind with children and inhalers and remote consultations, we do need to think about, you know, the confidentiality side of things and the governance side of things when it comes to video consultations. So I've been to various places to get some tips around doing that, and it's important that, you know, we follow that governance. I think with children as they grow older as well, just be aware when you're thinking of masks and spacers, when they get above the age of 5, if we are in the community pharmacy or in the practice, it's important that we look and obviously be aware of the concerns that patients may have around their inhalers. But to be honest, the actual mask is not necessary maybe for all patients. So something to be aware of there above the age of 5. So we need to always be assessing inhaler technique and reviewing and repeating. And be aware, of course, of people that may have concerns about steroid use. So we need to make sure that we give them some good advice around that. Low dose, direct to the site of action, and highlighting that, of course, we're getting something that's naturally released in our bodies, and it's our bodies reacting too strongly. But just something I always like, and I think with EMIS templates, and something that community pharmacies might not be able to access this, but I do find having good templates is something that's helping me. And Arden's has got a good template and gives you really good links, because I think we're in a day and age where we should have digital personal asthma plans. We should be able to do the asthma control test digitally as well, rather than filling out forms all the time. So I'm finding the Arden's has been quite useful when it comes to the sorts of using the right technology. And I can't I mean, I was one of the pharmacists involved in helping develop Rightbury, so I have to give that a plug. It's a great place to not only learn about the inhalers, but of course the medications inside them as well, which is great. Yeah, so just one last thing to end off with mine. If you do hear a whistle, by the way, with most dry powder inhalers, and also with things like clip tones and flow tones and all these tools that we've got, if you hear a whistle, it's generally a good sign. But for a spacer, if you do hear a whistle, with the commonly prescribed aero chamber inhaler, for example, if you hear a whistle, you're inhaling too quickly. So I thought I would end with that, because we can make mistakes if we don't have the training ourselves. And I thought this article about remote consultations in the PJ with Nina Barnett and colleagues was very good, just around some of the words we could use around setting the scene and making sure patients understand, because we can't be didactic with this. It has to be partnership, working with our patients, of course.